Today we're doing Nursing Care of the Child with Alteration in Genetics, Chapter 49. Objectives for this chapter include talking about your role as the nurse and responsibilities when caring for the child diagnosed with the genetic disorder, identifying interventions related to the lab and diagnostic tests used in the management of genetic disorders, distinguish the various genetic disorders that happen in childhood, be able to devise an individualized nursing care plan for the child with the genetic disorder, and develop child family teaching plans for the child with a genetic disorder. So when we talk about genetics, we're talking about the study of heredity, its transmission, and characteristics or variations. As the nurse, you'll come across potential or actual alterations in genetics in multiple clients, and you have to be able to detect problems right away and intervene in order to prevent complications. These genetic disorders are really a form of a disease caused by some abnormality in that person's genetic makeup or genome. Some genetic disorders will occur in several different family members through the inheritance of those abnormal genes, while others may occur only in one family member through something called spontaneous mutation. A genetic disorder is caused by either completely or partially altered genetic makeup or material. A familial disorder is more common in relatives of the affected individual, but may be caused by things like environmental factors, not genetic alterations. Many chronic disorders of childhood have a genetic or inherited cause. Common disorders suspected to be caused or influenced by genetic factors include things like birth defects, chromosome abnormalities, and neurocutaneous disorders. Also, intellectual disabilities, short stature disorders, connective tissue disorders, and inborn errors of metabolism. Genetic disorders can present at any age, but the most obvious and severe disorders are present in childhood. Let's just talk a little bit about the different abnormalities before we move on. So in some cases, genetic disorders, the abnormality is caused by problems with the chromosomes. Chromosome abnormalities do not follow straightforward patterns of inheritance. So this means that chromosome disorders can be inherited. However, a lot of them occur because of random events while the reproductive cells are being formed or during the early fetal parts of development. Most chromosome abnormalities occur due to an error in the egg or the sperm. The abnormality is present in every cell of the body when this occurs. Some abnormalities happen after fertilization, and that can occur during the mitotic cell division. This results in something called mosaicism, meaning that the chromosome abnormalities are not occurring in every single cell. When this happens, generally the person has a form of the disorder that is not quite as severe, or the symptoms are not quite as severe. So again, the mosaic form of the disorder is when the chromosome abnormalities don't show up in every cell. So in this case, the abnormality or the chromosome issue occurs after fertilization. Chromosome abnormalities can happen in about one in about every 150 babies that are born. And they'll suffer congenital anomalies and intellectual disabilities with these chromosome abnormalities. They can occur on autosomal or non-sex chromosomes, as well as the sex chromosomes. And abnormalities can be caused either by an incorrect number of chromosomes, like in those trisomy 18, trisomy 21 Down syndrome, or it can be from some sort of chromosome structure problem. Now, chromosome abnormalities of number often result of something called non-disjunction. And this is where the chromosomes the pair doesn't separate during the cell division, meiosis, or mitosis. Few chromosome numerical abnormalities are compatible with full-term development. The ones that you'll see us talking about are compatible with full-term development. The others will result in spontaneous abortion. So the numerical abnormalities that do support development to full term, because the chromosome on which the abnormality is present carries relatively few genes, are the chromosome 13, the chromosome 18, the chromosome 21, or the X. Common abnormalities of chromosome number are referred to as monosomies and trisomies. In monosomies, there's only one copy of a particular chromosome instead of the usual pair. So in this case, in the monosomy, we have a single chromosome missing. In the monosomy, where we have the single chromosome missing, okay, all fetuses spontaneously abort in early pregnancy, unless the child has the mosaic form. Remember, we talked about the mosaic form. So if the child has the mosaic form where the monosomy doesn't occur in every single cell, then they have a better chance for survival. Otherwise, if they don't have the mosaic form of this monosomy, then we will expect them to die, okay? Not survive full-term pregnancy. In trisomies, there are 3 of those particular chromosomes instead of the usual 2. So we have an entire chromosome added. The most common trisomies are trisomy 21 or Down syndrome, trisomy 18, and trisomy 13. And we'll talk about those a little bit more as we move on. So these abnormalities of the chromosome structure happen when the chromosome breaks and it loses a part of its chromosome. And during the repair process, the broken ends are rejoined together incorrectly. This causes structural abnormalities, and we can have too much or not enough genetic material because of it. The altered chromosome structure can take on different forms. Deletions can occur if part of the chromosome is missing, or we can see a loss of that portion of the chromosome. Duplications are seen when a portion of the chromosome is duplicated and an extra chromosome segment is present. So depending on the findings on how much chromosome material is involved on what we'll see clinically in the patient. Inversions happen when some of the chromosome breaks off at 2 points, and then it flips upside down and it's reattached during the repair process. So the genetic material is actually inverted. When we have inversion, there's actually no loss or gain of the chromosome material, and the carrier is phenotypically normal. But they do have an increased risk for things like miscarriage or having abnormal offspring that can be affected by these chromosome abnormalities. Ring chromosomes are seen when a portion of the chromosome is broken off in 2 places and formed a circle or a ring. The most clinically significant structural abnormality is a translocation, and this happens when part of one chromosome is transferred to another chromosome and an abnormal rearrangement is present. So look in your book on page 341, and that will show you the karyotype of a child with Down syndrome. All right, karyotyping is one of the prenatal tests that we use to diagnose or predict genetic diseases. And this karyotyping is actually a picture or pictorial analysis of the chromosomes, and it shows us a systematic arrangement of the chromosomes of a single cell by pairs. So the karyotyping is often used in prenatal testing to diagnose or predict different genetic diseases. Now, as a nurse, what will you do? You'll come across children that have these genetic disorders or people, okay? And that can happen in any clinical specialty area, all right? A lot of these kids grow up to be adults and they live long, well, productive lives. Okay, so I was saying as a nurse, you're going to come across different children with genetic disorders in every clinical specialty area. And this may include the school, the hospital, home care. And these children grow up to be adults who also will have needs as adults for different sorts of nursing services as well. You'll have to talk with the families, okay, who've been diagnosed with genetic disorders and have problems with fertility, or those that have a child that has some sort of genetic disorder or congenital anomaly. And sometimes it's not that easy to do this. A lot of times you're going to be the one that has the first contact with these parents, and you'll also be the one providing that follow-up care. Remember, with genetic disorders, they are important. They can be life-changing for the family and for the patient that has it, and they can lead to life-threatening situations. A lot of the information we use is highly technical now, and the field is still evolving. And again, we have all these diagnostic tests. We can test people and look at different things that cause these genetic disorders, but we don't always have a cure or a treatment for it. So we're going to have to do things like education, counseling, answering questions for these people in between that genetic counseling, referring them to that genetic counseling before they attempt to have other children. You are in that ideal position to help the family review what was discussed during the genetic counseling and answer additional questions that they might have. You also are able to provide that emotional support to the family during this challenging time. And then you can refer to the family to the appropriate agencies or support groups, resources, etc., that they're going to need. We use a lot of different medications and other medical treatments to treat the symptoms of genetic disorders. They don't have a specific treatment, so it's based on the symptoms or what the disorder is. There's no cure, so treatment focuses again on specific symptoms of each disorder. We also have to consider the involvement of multiple organs with some of these disorders and the complex medical needs of the child. Generally, we're going to use a multidisciplinary approach, and good communication is extremely important. So when we're caring for these children with the genetic disorder, it's going to involve things like assessment, nursing analysis, planning, interventions, evaluation. So a number of things related to the nursing process that will apply to the care of the child with genetic disorders. The overall understanding of the care involved for a child with an alteration in genetics is individualized, and the care is based on the specific needs for that child and family. Assessment of the child with a genetic disorder includes things like health history, physical exam, laboratory, and diagnostic testing. And then education. We also have to look at the medical history of the child with the genetic disorder. So first thing we want to look about is mom's pregnancy history. Any infections, any problems with her amniotic fluid, anything like that that we may need to take a closer look at. Any diabetes, any endocrine issues. Also, did mom take any medications during her pregnancy, any kind of drugs, anything like that that could have crossed over and could have done some sort of damage? What's the family history? Is there any genetic disorders in the family, any history of any issues along that line? The neonatal history of the baby, so anything during the birthing process. Was the baby deprived of any oxygen, any tools used like forceps, any sort of trauma, any sort of infections or bleeds that could have led to or caused an issue? And then a history of current illnesses. Anything going on with that child currently? How have they progressed? Okay. What kind of treatments have been used at home? So you're looking at the child's current and past medical history. You're looking for, again, the family history of genetic disorders, complications during the prenatal, perinatal, or postnatal period, changes in the developmental status or delays in the developmental milestones. And what they mean by changes in the developmental status is maybe the child was able to do something last week, and now this week, all of a sudden, they can't do it again. So information that's extremely important, okay, when we're looking at genetic disorders is the age of mom and dad, okay? So if mom is older than 35 and dad is older than 50, repeated premature births, breech deliveries, congenital hip dysplasia, abnormalities found on the ultrasound, abnormalities in those prenatal blood screening tests like the triple quadruple screen or the alpha fetoprotein, differences in the amniotic fluid or abnormalities in the amniotic fluid like polyhydramnios or oligohydramnios, multiple births, exposure to medications or known teratogens, and decrease in the fetal movement. That focused neonatal history is also going to help us identify genetic problems. We want to look at the baby's growth, okay? The symmetric intrauterine growth restriction, any large for gestational age without a reason, any hearing impairments, any persistent hyperbilirubinemia. Remember, we talked about that and how it can alter the brain, okay? It can do brain damage if there's too much bilirubin, if the body's not able to excrete it for some reason, or it just stays elevated all the time. The baby doesn't adapt well to the extrauterine environment, so they're not either maintaining their thermoregulation properly by controlling their temperature and their heart rate. Maybe they have a poor feeding. Maybe they're hypotonic or hypertonic. They may have seizures, or they may have had some sort of abnormal newborn screening. And then the family history also plays a critical role in identifying genetic disorders. So we're looking at information back for 3 generations. Is there a positive family history? Is there a likelihood of a genetic disorder in the child? How's their risk factors? So we want to look sometimes at the whole family dynamics. The family history can be important for things like major congenital anomalies, intellectual disabilities, genetic disorders, metabolic disorders, multiple miscarriages, stillbirths, developmental delays, psychiatric problems, chronic illnesses like diabetes, hypertension, kidney disease, blindness, asthma. Hearing impairments. So when we're looking at the history of the present illness, we also need to inquire about things like, again, mom's pregnancy history, any family history, any developmental delays in the child, any developmental milestones that they may have reached that now they can't reach that has changed, any developmental status there changed, seizures, hypotonia, hypertonia, any feeding problems, lethargy, failure to thrive, septic appearance, vomiting. Medications, and any dietary restrictions. So kids with these genetic disorders are frequently admitted to the hospital for other issues or complications and management of the genetic disorder itself. When you're doing that health history, you want to ask specific questions about when the client was diagnosed, developmental delays, any complications of the disorder like thyroid issues, cardiac issues, respiratory problems, seizures, what medications the child takes for complications associated with the disorder, any dietary restrictions, and any compliance with managing the regimen. So once we have identified the complications, then we can investigate further and manage the care of the child that is admitted. Next, we're going to talk about physical examination. Okay, so when we're looking at the child with the genetic disorder, we're going to do the same inspection, observation, palpation, auscultation that we do with everybody else. In this case, we're looking for major and minor abnormalities like surgical repairs. A major abnormality might be seen in a client who has an issue with their ears. So low set ears, 3 or more minor issues. Okay. I'm sorry, surgical repair would be a major issue. The low set ears would be a minor issue. So 3 or more minor issues, suspect a major problem. So if you have 3 or more of those minor issues, in children that do have chromosome issues or that have disabilities, a lot of times the ears will be abnormal. And one of the theories for this is that the ears and the kidneys are developed around the same time during fetal development. So a lot of times you will see that the kidneys have a problem, the ears and other things will have a problem that are associated with the development or during that time of the development of the kidneys. So let's talk about major and minor abnormalities. So low set ears are a minor anomaly. And again, this is associated with numerous genetic dysmorphisms. Major congenital anomalies are considered things like cleft lip, cleft palate, congenital heart disease, neurotube defects, chromosome abnormalities, omphalosully, renal agenesis, absent or limb deficiencies, generalized dysmorphism, and ambiguous genitalia. The minor anomalies are considered flat occiput, prominent occiput, triple hair whorl, flat bridge nose, earlobe creases, earlobe notched, cup-shaped ears, small ears, cleft uvula, webbed neck, short neck, extra nipples, sacral dimple, tapered fingers, overlapping digits, syndactyl, meaning that you have extra digits, hemangioma, and nevis. These are markings on the skin, which you should have remember from when we were going through newborn abnormalities and markings that you might find on the newborn. So you're inspecting and observing, you're looking for the major and the minor abnormalities. Again, major would be something like a surgical repair, or minor would be something like low set ears. And for 3 or more minor anomalies or abnormalities, you should suspect a major problem. All right, so you're observing for abnormal or foul odors from the excretions. Certain metabolic disorders can cause the child to emit specific odors, especially from things like their sweat, their saliva, their sputum. So these different odors are associated with different inborn errors. So one of these odors could be a mousy or a musty smell, and you would see that from PKU. Another one could be the maple syrup urine disease, which causes a maple syrup or a burnt like sugar-like smell. Tyrosinemia, which can cause a cabbage-like rancid butter smell. And trimethylaminuria, which can cause a rotting fish type of smell. You're also auscultating, okay? You're listening for heart murmurs or dysrhythmias. In children with congenital heart issues, a lot of times they will have ventricular septal defects, cardiac structural problems. So we have to consider their needs. And then you're palpating for things like an enlarged liver or spleen. That can help us detect hepatosplenomegaly or an enlarged spleen and liver. A lot of times these may associate or indicate a metabolic disorder. So again, the PKU or the phenylketonuria, the child may have a mousy or musty smell. With the maple syrup urine disease, they may have a maple sugar or burnt sugar or curry smell. The tyrosinemia, they may have a cabbage-like or a rancid butter smell. and the trimethylaminuria, they may have a rotting fish smell. All right, lab and diagnostic tests most commonly used to help the doc or the nurse practitioner in diagnosing, can I talk this morning, and diagnosing the disorder. All right, these help us also determine how to treat it. So either way, you as a nurse have to know what the tests are, how they're obtained, and what they're used for. So first, we're going to talk about amniocentesis. All right, this is an ultrasound guide, and we use it to determine the location of the placenta. A needle is guided through the abdomen and the uterine cavity to obtain the amniotic sample. So they use a sterile needle to aspirate the fluid from the amniotic sac to analyze it. And it's recommended if mom is over 35, the couple already has a child with a chromosome abnormality such as Down syndrome or a metabolic disorder such as Hunter syndrome. If mom is a carrier of an X-linked genetic disorder such as hemophilia, in which she has a 50% chance of passing it on to a son. If a parent is known to have a condition such as Huntington chorea that's passed on by autosomal dominant inheritance, giving the baby a 1 in 2 chance of inheriting the disease. If both parents are carriers of an autosomal recessive inherited disorder such as Tay-Sachs disease, sickle cell anemia, and giving the child a 1 in 4 chance of bearing an affected child. If the results of the triple screening test and the ultrasound are abnormal, and amniotic fluid evaluation may be necessary to determine whether there's a fetal abnormality. So amniocentesis is valuable because it can help detect fetal abnormalities, especially those chromosome and neurotube defects. It can help detect hemolytic disease of the fetus. It can help diagnose metabolic disorders, amino acid disorders, and mucopolysaccharidosis. It can help us assess the fetal lung maturity. The lungs are the last organ ready to function on their own. So that's around 35 weeks. It can help us detect the presence of meconium or blood. It helps measure amniotic levels of estriol and fetal thyroid hormone. It helps us identify the baby's gender. And diagnostic second trimester amniocentesis is usually performed between the weeks of 16 and 20. Sometimes you'll see 15 to 18, so it can be done as early as week 14 if there's an issue. Most tests require the cells to be cultivated in the lab. Okay, so results are usually not available for about 7 to 10 days, but it varies by laboratory. All right, some tests that are used to detect things like Tay-Sachs disease, Hunter syndrome, and neurotube defects can be performed right away. Complications include miscarriage, fetal injury, amniotic fluid leakage, infection, spontaneous abortion, premature labor, maternal hemorrhage, amniotic fluid embolism, abruptio placentae, and damage to the bladder of the intestines. So during this procedure, you're gonna ask the patient to change into the exam gown and empty her bladder. Explain she'll be positioned on the exam table on her back, and the abdomen will be draped. Before the test, the fetal heart rate, mom's vital signs, and ultrasound are monitored. The ultrasound is used to help monitor the needle placement into the pocket of the amniotic fluid and check the fetal well-being. The skin is prepared with an antiseptic. and the doc may choose to inject the skin with lidocaine to numb the area. However, some doctors feel that it's more painful than completing the amniocentesis itself, so they don't provide the anesthesia. The doc will insert a 20-gauge spinal needle into the amniotic cavity, aspirate the amniotic fluid, and put it into a test tube. The doc will remove the needle, and the insertion site is covered with a Band-Aid. Mom and baby will be monitored for a short period of time to make sure both are doing well. Generally speaking, complications of amniocentesis again include spontaneous abortion, spontaneous rupture of membranes, trauma to the fetus or the placenta, bleeding, premature labor, infection, and Rh sensitization from fetal bleeding into the maternal circulation. So because of this, if mom is Rh negative, we'll have to give that Rogaine. Okay, because of the potential severity and the possible complications, amniocentesis is contraindicated as a general screening test, meaning we don't just do it for the sake of doing it. Abnormal test or failure of the tissue cultures to grow may necessitate repetition of the test. And then you could read up more if you wanted to know about the analysis, but there are ways to analyze the fluid. We look at the color of it and we measure other things that are inside the fluid. All right, chorionic villi sampling. This is usually done about 7 to 11 weeks of gestation, and we're looking for early detection of genetic abnormalities. So in this, we're going to take a small amount of tissue directly from the chorionic villi. That's that little minute finger-like vascular projections of the fetal chorion that mix with the maternal uterine tissue to form the placenta. So in the lab, chromosomes of these cells are analyzed for the number and type. Remember, extra chromosomes, one too many, are usually seen in those chromosome disorders, those trisomies, like Down syndrome, trisomy 18, trisomy 13. And remember, the monosomies are the ones that we talked about that are from having only one chromosome, right? One chromosome, meaning that these babies, unless they have that mosaic form, are likely to abort spontaneously before the full term is reached. All right, so in these patients, we see those extra chromosomes present in the Down syndrome, and they can be identified. Okay, so we can also do other lab tests to look. So this tests for chromosome abnormalities, fetal or metabolic blood disorders, specific genetic conditions of the fetus. And it's performed if the mom is considered at high risk for having a child with a genetic disorder or an abnormal ultrasound, or the chorionic villi sampling cannot detect the alpha fetoprotein levels, so it cannot detect neural tube defects. So we don't use it for that. So the chorionic villi sampling is going to involve aspirating the chorionic villi from the placenta for the prenatal diagnosis of genetic disorders. Remember, we talked about these finger-like projections that surround the embryonic membrane, and eventually they help develop the placenta. So the cells obtained are a sample of the baby, not the mom. The origin can be analyzed for fetal abnormalities. Experts believe that the villi in the chorion frondosome reflect fetal chromosome, enzyme, and DNA content. So when we look at chorionic villi sampling, it's a prenatal test for quick detection of fetal chromosome and biochemical disorders that's performed in the first trimester of pregnancy. Preliminary results could be available as early as an hour, but usually 24 hours depending on the lab and the location. Either a transcervical or transabdominal approach can be used to obtain the chorionic villi sampling specimen. In transcervical, a sterile catheter is induced into the cervix using direct visualization with real-time ultrasound. A small part of the chorionic villi is aspirated through the catheter into the syringe. In the transabdominal sampling, the mom's abdomen is cleaned and an 18 gauge or 20 gauge needle is then inserted into the chorion frondosum under ultrasound guidance. The specimen is then aspirated into the needle, and the aspirated villi are placed in a medium for cytogenic analysis. The cells from the villi normally have the same genetic and biochemical makeup as the embryo. So examining these villi cells gives us a complete picture of the genetic makeup for that developing fetus. The chorionic villi sampling can detect fetal karyotype, hemoglobinopathies, such as sickle cell anemia, alpha thalassemias, and some beta thalassemias. PKU, alpha-1 antitrypsin deficiency, Down syndrome, Duchenne's muscular dystrophy, and factor IX deficiency. The test also helps identify sex and early detection of X-linked conditions in the male fetus. Test complications include inability to obtain or failure to obtain the tissue, ruptured membranes, leakage of the amniotic fluid, bleeding, intrauterine infections, spontaneous abortion, contamination of the specimen, and possible Rh iso immunization. If the patient is Rh negative, administer the RhoGAM as ordered to cover the risk of the Rh sensitization from the procedure. Also, research indicates that some limb malformations are associated with neonates that whose mother has undergone the chorionic villi sampling, but it appears to be low if the chorionic villi sampling is done after 10 weeks of gestation. So if it's done before 10 weeks, it could cause the baby, or the baby could be born with some sort of limb malformation, meaning they might have a problem with the limbs, their hands, their feet, their legs. Okay. Most women feel physically and emotionally drained after they go through the chorionic villi sampling. So we want to teach the patient not to drive home on her own. Don't make any more plans for the rest of the day. And she should call the physician if she has any concerns or complications, such as fever, vaginal discharge, vaginal bleeding, or cramping. Again, for this, we're monitoring mom and the baby before and after the procedure. Another test done is a blood test, and that's a triple quadruple screen. And this measures the level of 3 substances, okay, AFP, alpha fetoprotein, unconjugated estriol, and the human growth gonadotropin, or HCG. By detecting different chemical patterns, the test predicts if there's an increased risk of bearing a child with a chromosome abnormality or an open tube defect. So things like Down syndrome, extra chromosome 21, trisomy 18, extra chromosome 18. With this, the neonate can die within hours of birth, but they may live for months or in some cases years. Spina bifida, this is where the baby's spine doesn't close properly. And it can also help determine the size and location and severity of it, so that they can prepare for surgery at birth if required. Also, ancephaly, which is the most severe type of neurotube defect, and where the brain and skull don't form properly. Babies are stillborn, or usually they die within a few weeks. Some of these babies do live to be a little bit longer, but it's rare. Omphalocele and gastroschisis, which is improper closure of the abdominal wall. And also they can look at the severity, depending on the size and the location of the opening. The surgery may be able to correct the problem depending on the severity. So suggestive, not definitive. So triple screening doesn't definitively answer if the fetus has a birth defect. It only suggests that there's a possibility for the birth defect. And then depending on the severity of the defects with some of the ones we talked about, on whether or not they can actually help the baby survive at birth through some surgical procedure. In some cases, results appear to be abnormal because the fetus is younger or older than what we initially estimated, but suspicions can be confirmed on these tests by amniocentesis. So again, this is a screening test. The quadruple screen is used in low-risk pregnant women to determine pregnancies, increased risks for open neural tube defects, Down syndrome, and trisomy 18. It's usually performed between the weeks of 15 to 21. All right, and remember, we just said a normal test doesn't guarantee a healthy baby, and an abnormal test doesn't guarantee the baby will have a problem. All right, but it would just help us prepare for the problem if that issue was then confirmed through an amniocentesis or some other type of testing. Fetal nuchal translucency. This can be combined with something called pregnancy-associated plasma protein and beta-HCG. And we use ultrasound prenatal screening to help identify higher risks of Down syndrome, trisomy 18, trisomy 13, and Turner syndrome. Using the ultrasound, we can look at the amount of fluid behind the baby's neck, known as the nuchal fold, and increases in this fluid increase the risk for chromosome abnormalities. During the ultrasound, other markers that may be looked at are presence of nasal bones. In patients with Down syndrome, we may see hypoplasia or absence of their nasal bones. We may see shortened femurs or humeruses, and increases the risk of trisomy. Echogenic foci in the heart can increase the risk of Down syndrome and can be associated with other chromosome abnormalities. A blood test is performed to determine the level of the other two hormones, the PAP-A and the beta-HCG. Using a combination of the results of the ultrasound and the blood test, the risk of having a baby with Down syndrome is then predicted. Any pregnant woman presenting by 11 to 13 weeks gestation can be screened. This is particularly for women with an increased risk or a desire for screening for Down syndrome, trisomy 13, or trisomy 18, or Turner syndrome. It must be performed between weeks 11 and 13. Genetic counseling should take place before testing is completed, and positive tests require follow-up and additional genetic testing and counseling. Okay, ultrasound. This is a safe, non-invasive look at the baby. We use a transducer on the mom's abdomen, and we listen and look at the sound waves directed at the fetus. The sound waves are reflected back through the tissue and recorded on a screen. So this looks at structural malformations. It's usually done between 18 and 20 weeks gestation. Early ultrasound can be performed between 11 and 14 weeks to evaluate for Down syndrome or other chromosome abnormalities. Cell-free fetal DNA testing. This is where we look at the fetal circulating cell-free DNA by taking a sample of mom's blood. It's an advanced screening test, and it can detect fetal aneuploidies for chromosome 21, 18, and 13. It can also detect X or Y chromosomes. It's indicated for women that have a high-risk pregnancy, anyone that's 35 or older at the time of delivery. Testing before the mom gets pregnant reveals whether or not she has an increased risk of having a baby with trisomy 21, 18, or 13, and previous pregnancy with the trisomy. Also, parental balanced Robertsonian translocation would be a cause for or an indication for doing this test. Okay, so this Robertsonian translocation is one where the whole chromosome is joined end to end with another. And it typically only involves chromosomes 13, 14, 15, 21, and 22 because the ends have a similar repetitive DNA sequence that helps them to make this fusion or this joining. So families that have this Robertsonian translocation involving the chromosome 13 or 21 are extremely high risk of having children with the translocation plateau or Down syndrome. Okay, so this cell-free fetal DNA testing can be performed as early as 10 weeks in. Results are usually available in a week. It's not usually recommended if someone's a low-risk pregnancy, and that's due to the lack of evaluation. Positive test results require more invasive testing and genetic counseling, and then high detection rate with low false positives. The percutaneous umbilical sampling is next. And we use this to obtain blood samples directly from the fetal circulation. It's indicated for prenatal diagnosis of inherited blood disorders, detection of fetal infections, assessment of the acid-base status of a fetus with the intrauterine growth retardation. All right, typically we use this to detect chromosome abnormalities, especially when diagnostic information cannot be obtained through the amniocentesis, the chorionic Villi sampling, or the ultrasound, or the results of those tests were inconclusive. We can also use the percutaneous umbilical blood sampling procedure to administer blood products or drugs directly to the fetus, allowing for treatment of the fetus in utero. It also reduces the risk of prematurity and mortality for a neonate with erythroblastosis fetalis, which is hemolytic disease of the newborn due to Rh incompatibility. This can be done at 18 weeks or after. Complications can include miscarriage, blood loss, infection, premature rupture of the membranes. The risk of the pregnancy is greater than with the amniocentesis or the chorionic Villi sampling. And we're starting to use this to replace the fetoscopy. Okay, so a little more risky for this. They are now using it to replace the fetoscopy. All right, so for this, we're using the fine needle. It's passed through the mom's abdomen and the uterine wall into the vessel in the umbilical cord. Ultrasound is used to guide it. The mobility of the cord complicates the procedure. The cord's more stable, closer to the placenta, and that allows for more accurate puncture. The Kleihauer-Beck procedure is used to detect fetal cells in the maternal blood and is immediately performed on the blood sample obtained to ensure that it's fetal in origin. It's performed anytime after 18 weeks, and it can help diagnose fetal coagulopathies, hemoglobinopathies, hemophilias, and congenital infections. It also provides for rapid fetal karyotyping. Rather than analyzing amniotic fluid to detect abnormalities, percutaneous umbilical sampling directly assesses fetal blood. This is especially helpful in a patient who may have immunized pregnancy from Rh disease or from another antibody sensitization. All right, fetoscopy. This is an endoscopic procedure that allows direct visualization of the fetus through the insertion of a tiny flexible tube called a fetoscope. It's inserted through the abdominal wall and into the uterine cavity. The ultrasound is then used to guide the placement of the scope. Direct visualization can evaluate the fetus for severe congenital anomalies like neurotube defects. Fetal blood samples from the umbilical cord can be obtained and tested for congenital blood disorders such as hemophilia and sickle cell anemia. Fetal tissue samples, usually skin, can be collected for genetic testing. So in this procedure, we use a fetoscope, which is a telescope-like instrument with lights and a lens. It's inserted into the amniotic sac, where it can be viewed and photograph the fetus, where it can view and photograph the fetus. This procedure makes it possible to diagnose through blood and tissue sampling blood and skin diseases that amniocentesis can't detect. Fetoscopy is a relatively risky procedure, and because other safer techniques are becoming more available, it's not widely used. So when the fetoscopy is done, it's usually performed after or during that 18th week of pregnancy. Again, complications include spontaneous abortion, premature delivery, premature rupture of the membranes, amniotic fluid leak, intrauterine fetal death, and infection. And we're going to monitor the baby before and after the procedure. For gene testing, this is currently available for several inherited diseases. And at this, we analyze the DNA, the RNA, the chromosomes, the proteins, the metabolites, and any biochemical agents. Specimens for gene testing can be obtained from different sources. So we can get them from the leukocytes from blood. This is the most common and easily obtained site. During pregnancy, amniocentesis and chorionic villi sampling, and fetal tissue or products of conception after a miscarriage. The most common use is DNA or chromosomes isolated from the blood. With this, we use direct detection of abnormalities in the genes and the chromosomes by analyzing that DNA using a DNA-based test or a cytogenic test to look at chromosomes and other methods. The cytogenic test also includes a FISH to assist in detecting chromosome abnormalities like duplication, deletion, rearrangement, and translocation. This helps us detect abnormalities that may indicate actual disease or predict future disease indicated in evaluating for congenital anomalies, intellectual disabilities, growth retardation, recurrent miscarriage, or to determine the reason for the loss of a fetus and prenatal diagnosis of genetic disease. We want to provide support, information, and resources to the family and refer the patient for genetic counseling before and after the test. And then newborn screening. These are different blood screenings that we do right after birth to identify different life-threatening illnesses that have no immediate visible effect, but can ultimately lead to some physical, intellectual, or disability for the baby, even death. Most states have a routine type of screenings that they do, but every state dictates to which disorders to screen for. So you'll go by what the laws are in that state or by what the policy of your facility is. That can vary from state to state. This helps us to identify disease processes or chromosome abnormalities in the newborn so that treatment can start early to prevent any impact of the disorder, such as severe cognitive impairment or death. Remember things like PKU. If we were to give the baby protein or some other issue, it could lead to brain damage, and that brain damage could be irreversible. So we want to screen for that PKU within a certain period of time. Refer to each state's protocol for the fetal newborn screening for endocrine disorders, explain to the family and the rationale for the procedure, collect the blood sample, and collect prior to the blood transfusion if possible. Ideally, this is performed after 24 hours of age. We would obtain the specimen as close to the time of discharge from newborn and labor delivery as possible, but no later than 7 days of age. Screening typically occurs between 24 to 48 hours after birth. The test is less accurate if it's done before 24 hours of age and should be repeated by 2 weeks of age if the newborn is younger than 24 hours. Some states now require a repeat screen at 2 weeks of age. Make sure you use the appropriate follow-up with the newborn screening results, and results should be available in 2 to 3 weeks for this test. So again, these are the major tests that you're going to have to know. Okay, the amniocentesis under ultrasound guidance requires informed consent, looking for chromosome abnormalities and elevated alpha fetoprotein. Metabolic diseases. Okay, it can be done between 15 and 20 weeks, but normally between 16 to 20. At 35 weeks, it can tell us about fetal lung maturity. We look for warning signs. What are those dangers? What are the risk factors for the amniocentesis? So it would be things like miscarriage, okay, leaking amniotic fluid, premature labor, spontaneous abortion, those kind of things. So we're monitoring the baby before and after the procedure. And if mom is Rh negative, we will probably give Rogaine here because there's a possibility of the blood mixing with the babies. The chorionic villi sampling, this occurs between 10 to 13 weeks. Remember, we can do it cervically or abdominally. We talked about that. It is going to require informed consents. Okay. Warning signs can be accidental abortion, infection, bleeding, amniotic leaks, fetal limb deformities. Remember, we're going to take that tissue and that can cause the baby to have a malfunction with their limb. Okay, so for this one, also, we might have to give the RhoGAM if mom is Rh negative. We're monitoring the baby before and after the procedure. Next one is the alpha fetoprotein analysis. We do that between 16 and 18 weeks. We're looking for neurotube defects. Okay, remember an elevation in this indicates neurotube defects and a decrease indicates Down syndrome. The triple screen, quad screen, sequential screen. This is done at 16 to 18 weeks. Okay, so we're looking at those three things: the alpha fetoprotein, the HCG, and the unconjugated estriol. For this one, we're testing for both neurotube defects and the trisomies. Okay, remember trisomies are, we have 3 chromosomes instead of 2. So that's going to be in like Down syndrome, trisomy 21, trisomy 18, and trisomy 13. Elevated risk increase of these markers includes increased risk for the neurotube defect and decrease they're at risk for the trisomies like the Down syndrome, the trisomy 18, and trisomy 13. Remember, with these tests, you want to educate the mom that normal test doesn't guarantee a healthy baby and abnormal test doesn't guarantee an unhealthy baby. If that does come back abnormal, then we would do additional testing. The nuchal translucency, this is where we're looking at the fluid behind the baby's neck using that ultrasound, and we're trying to identify risk factors for Down syndrome, trisomy 13, trisomy 18, and Turner's syndrome, done between 10 and 14 weeks. Genetic counseling, okay, before the test. And a positive test would require follow-up test and genetic counseling. We're also looking at the crown rump length of the baby. So the length measurement from the crown to the rump and the measurement of that nuchal fold. The ultrasound, which looks at the baby's viability. So we're looking for structural malformations, usually done between 18 and 20 weeks. Looking at blood flow studies, okay, the velocity of the blood flow, and Down syndrome and other chromosomal abnormalities. The cell-free fetal DNA testing, where we're looking at the DNA taken from the sampling of the maternal blood. This is an advanced screening test, usually only done on those high-risk pregnancies. Can be done as early as 10 weeks with results in a week. Not recommended for low-risk pregnancies, and positive results require more invasive testing. The percutaneous umbilical sampling, we can use this to check for fetal anemia. It also can be used for fetal karyotyping, but there's an increased risk for the procedural issues. Usually performed around 18 weeks. Complications can include miscarriage, blood loss, infection, premature rupture of the membranes. Risk to the pregnancy is greater here than with an amniocentesis or the chorionic villi sampling. And we're starting to use this to replace the fetoscopy. We're looking for chromosome abnormalities. Okay, and with this, remember, we said we can also use this to give blood products to the baby or drugs. The fetoscopy, that's that endoscopic visualization, direct visualization through that small tube inserted through the abdominal wall and into the cavity, performed around the 18th week of pregnancy, looking for risk factors for congenital anomalies. And it also can be used to put in shunts on the fetus. Complications for this are spontaneous abortion, premature delivery, premature rupture of the membranes, amniotic fluid leaks, intrauterine fetal death. We're going to watch the baby before and after the procedure. Gene testing. Okay, this is currently unavailable for many inherited diseases, but we use it to detect abnormalities. And we're going to provide support, information, and resources to the family, refer them for genetic counseling before and after the test. So now we're looking at risk factors, okay? Mom hasn't gotten pregnant yet, but is considering it, all right? So we're looking at what is the potential that they'll inherit or contract certain diseases. All right, some other less common chromosome disorders like Prader-Willi syndrome. These kids like to eat a lot. Sometimes they have to lock the refrigerator up. This is an abnormality on the chromosome 15. It causes severe hypotonia, obesity, short stature, small hands and feet, hypogonadism, the hyperphagia, and intellectual disabilities, which can range from mild to severe. It affects 1 in about 16 to 25,000 babies. The Angelman syndrome, also on the chromosome 15. And this, you'll see microcephaly, or a small head with flatness at the back of the head. These clients tend to be fair-skinned with light hair. They'll have a large mouth with a large tongue profusion. They may appear jerky or ataxic, something like a puppet sort of gait. They can present with seizures, and they'll have uncontrolled bouts of laughing, smiling. They're easily excitable, and they may have developmental delays or speech impairments. Usually they'll have severe intellectual disabilities. The Cry-Ducat syndrome. This affects about 1 in 20,000 to 50,000 babies. You'll see hypotonia, short stature, a slow growth, low birth weight, failure to thrive, and they'll have this characteristic weak cat-like cry during the infancy. Microcephaly with a protruding metopic suture, a moon-like face, bilateral epicanthial folds of the skin over the eyelids, high arched palate, wide and flat nasal bridge, micrognathia, which is a small receding chin, wide set eyes, low set malformed ears, semion crease, and intellectual developmental disabilities and delays. Wolff-Hirschhorn syndrome. This is the patient's going to have hypotonia, intellectual disabilities, delayed growth, development, Seizures, characteristic facial features with the broad, flat nose, the high forehead, the widely spaced protruding eyes, and the microcephaly. And then Williams syndrome, where they'll have cardiovascular disease, aortic stenosis, hypertension, distinct facial features described as elfin-like. So we'll go through those when we look at the picture. And then the Beckwith-Wiedemann syndrome, which the baby is a lot larger than normal growth, okay? And they grow at an unusual rate, and then the growth suddenly slows. And later childhood with adults, they're not usually tall, but specific parts of the body may grow larger, leading to an asymmetrical appearance. And then 22q11 deletion syndrome or DiGeorge syndrome. This is hypoplasia and agenesis of the thymus. So they're probably going to have some issues with their immunity system. All right, parathyroid glands, hypocalcemia, hypoplasia of the auricle and external auditory canal, cardiac anomalies, immune system anomalies, cleft palate, short stature, distinctive face appearance, elongated face, almond-shaped eyes, wide nose, and small ears. We'll look at that. So first one, Prader-Willi syndrome, okay, abnormality on chromosome 15, severe hypotonia, obesity, short stature, small hands and feet, hypogonadism, like to eat a lot, hyperphagia, insatiable eating, like they just continue to eat and eat and eat, and intellectual disabilities. The Angelman syndrome, remember I said they're going to have the light skin, the light hair, flatness at the back of the head. The head's going to be a little bit smaller for the body, the large mouth with the protruding tongue and seizure potential. The Cry-Do cat, okay, this is a missing piece of chromosome 5. You can see it missing here in this deleted region. So the patient will have a distinctive cry that sounds similar to a cat, severe intellectual disabilities, microcephaly, low birth weight and slow growth, hypotonia, wide set eyes, small jaw, and low set ears. With Cry-Do cat, if the children live past 1 year, they usually have a normal life expectancy. Wolff-Hirschhorn syndrome, the abnormalities on the chromosome 4. These clients will experience hypotonia, intellectual disabilities, delayed growth and development, seizures. Facial features will be broad, flat nose, high forehead, and wide space protruding eyes, along with the microcephaly or the small head. Williams syndrome, this abnormality is on chromosome 4. It's going to affect multiple systems, including the cardiovascular system. They'll have them elfin-like facial features. So this means they'll have a broad forehead, flat nasal bridge, short nose, broad tip, full cheeks with the wide mouth, full lips, small wide-spaced teeth with some abnormalities, hypercalcemia in the early pubertal stages. They'll reach puberty early, and structural abnormalities of the kidneys, delayed bladder training, and urinary frequency. These will also have learning disabilities, intellectual disabilities, ADD, sensory issues, tactile, and sounds. And then they're more outgoing, okay, and engaging than some other people. Beckwith syndrome, this is an abnormality on the chromosome 11. So we're going to see this large growth at an unusual weight, but remember it's going to be asymmetrical, so it's not necessarily height, but certain part of the bodies will grow faster than others. The abnormally large tongue, and these clients will have kidney problems. DiGeorge syndrome, this is the abnormality of that chromosome 22. These patients will present with hypoplasia or agenesis of the thymus and the parathyroid glands, leading to immunity issues, hypocalcemia, hypoplasia of the auricle, distinctive facial features with the elongated face, the almond eyes, the wide nose, and the small ears, and then additional developmental delays. Okay, trisomy 21, Down syndrome. This is caused by the presence or part of an extra 21 chromosome. It's the most common chromosome abnormality associated with intellectual disability. At conception, a lot of the trisomy conceptions result in spontaneous abortion. It can be seen in any race, age, or economic level, but a higher incidence found with women that are older than 35 when they deliver. This is explained that 90% of the cases with the extra chromosome 21 originates from the mom. So the likelihood of having a baby with Down syndrome is only 1 in 1,000 for women under 30. But by the time you get to age 35, your chances of having that baby go down to 350. And then by the time you're 45, the chances of you having that Down syndrome baby are 1 in 35. So it's associated with intellectual disabilities, the Down syndrome, characteristic facial features like the slanted eyes, the depressed nasal bridge, and other health problems, cardiac defects, visual and hearing impairments, as well as intestinal malformations and increased susceptibility to infection. However, we've seen a lot of improvement over the years, and these children, live a lot longer now. Before they would die like in their early 50s, and now we see them living, well into their 70s. So some other features you'll see are the low set ears, the hyperflexibility, the muscle hypotonia, the wide spaced eyes. They'll have a ulnar loop on the second digit, ulnar loop on the second digit, deep creases across the palms, flat facial profile, small white crescents on the iris, the open mouth with the protruding tongue, and the broad, short fingers. Again, cardiac defects, visual, hearing, and impairment, intestinal malformations, increased susceptibility to infection. All this is Down syndrome. So some of the cases involve a translocation, okay, that we talked about before, where part of the chromosome breaks off during the cell division, either before or at conception, and then it reconnects during the repair process to another chromosome. Usually this is going to happen with chromosome 14. The cells will remain with 46 chromosomes, but the extra portion of the number 21 chromosome causes these clinical findings. Some children will develop the mosaic form, meaning it won't affect all of the cells, just some of the cells. And the translocation, or where it breaks off and then forms with the third chromosome like that, is not generally associated with the advanced maternal age. So most of the time, you'll see just the extra chromosome in the moms that are over 35 with the translocation, where part of it breaks off and then it forms the third chromosome by reattaching during that repair process, is not associated with the older age. So the Down syndrome, or the trisomy 21, is caused usually by the non-disjunction or the translocation before, at, or after conception. All right. So when they join, again, they're going to result in 23 pairs or 46 chromosomes, but sometimes that extra chromosome will originate in the development of either the egg or the sperm, resulting in an embryo with 3 chromosomes in all cells. Okay, that results in those characteristic features and birth defects of Down syndrome. The non-disjunction results in the presence of 3 chromosome 21s in all cells and is responsible for about 95% of the Down syndrome cases. And then about 1 to 2% of the non-disjunction occurs after fertilization. In that case, if it happens after fertilization, remember they'll have the mosaic form, meaning that they'll have some of the symptoms, but it's going to be way milder, not as bad. And then about 3 to 4% involve that translocation, which has nothing to do with mom's age. It's where part of the chromosome breaks off and then reattaches to another chromosome during the repair process. So how are we going to manage it? All right. So for one, we're going to need a multidisciplinary team, okay, to address all the different components. So pharmacy, cardiology, ophthalmology, GI, nursing, physical therapy, occupational therapy, psychology, teachers, parents. Okay. Overall focus of therapeutic management is to promote the child's growth and development. And you see these kids with Down syndrome. They star on TV shows. They live productive lives. So they're actually most of the time doing pretty well. They'll need the same immunizations as any other child as recommended by their physician or the Pediatrics Association. Okay. Congenital heart disease will occur in about half of these kids. So cardiac problems can be minor to major. And so they'll be on different medications depending on what sort of defect they have or what sort of surgical interventions they've had to have. They also have an increased incident of GI disorders. So usually celiacs, but also constipation and Hirschsprungs from intestinal malformations and some with the imperforate anus, which will require a surgical intervention. Hearing and vision impairments common. About 75% of these kids will have a hearing loss. Otitis media is a common problem and a common cause for the hearing loss. About 60% of kids with Down will have some sort of eye disease, so they need regular evaluation of the vision and the hearing. They will also have obstructive sleep apnea. That's about 50% to 75% of the kids. And parents often don't know that their child has a sleep disturbance. So you have to be diligent in monitoring and looking for these signs and symptoms and asking questions also. The child with Down syndrome also has a higher incidence of thyroid disease, which affects their ability to grow and function cognitively. Most of the time, it's going to be hypo or underactive thyroidism. So we're going to do periodic thyroid testing on them as well. And then these kids are higher at risk for obesity, delayed dental issues, and increased risk for type 1 diabetes in certain kids with Down syndrome. Any unusual neck pain, unusual posturing of the head, change in gait, loss of upper body strength or abnormal reflexes, any change in bowel or bladder functioning is noted in the child with Down syndrome should be reported and evaluated immediately. Okay, they'll also have a risk for atlantoaxial instability, which is increased mobility of the spine. In most cases, they're asymptomatic. However, symptoms do appear. Spinal cord compression may be occurring. So screen for atlantoaxial instability, especially if the child is involved in sports. So early intervention could be physical therapy, occupational therapy, speech therapy. We want to encourage, accelerate dependence and development in these children. Independence, I'm sorry. Health history, we're usually looking at this is usually diagnosed prenatally. So what are some of the things that we're looking at for the health history? Let me just take it back a notch before we go into the early health history. Okay. Children are going to need early intervention, these kids. Okay. So this is specialized programs, resources available, and it can include PT, occupational, speech therapy, focusing on stimulation and encouragement to help those children accelerate development and to prevent some of those developmental delays. Also, they can progress through the same developmental stages as any other child. They just do it on a different timetable. So children with Down syndrome do learn how to walk, but they'll walk at 24 months versus a child without Down syndrome who might walk at 12. Things that might contribute to that delay are the hypotonia, the ligament laxicity, the decreased strength, the enlarged tongue, the short arms, and the legs. Parents can also benefit from the early intervention programs because of the assistance from other people. All right, health history. This is usually diagnosed prenatally using that perinatal screening that we were talking about and those diagnostic tests. If it's not, most cases are diagnosed within the first few days of life based on physical characteristics associated with Down syndrome. These moms can be at high risk for delivery, so you want to make sure that she's not. Look at the pregnancy history, any past medical history for risk factors such as lack of prenatal care or screening, abnormal prenatal screening or diagnostic tests for Down syndrome, the fetal nuclear translucency, the triple quadruple screening, the ultrasound, and the amniocentesis. Is the mom older than 35 years old? The older infant or child known to have Down syndrome is often admitted to the hospital for corrective surgery or some complication of the disease, such as an infection. So get a full description of the present disease, the chief complaint. If the child is returning for a visit or a hospitalization, the health history should include questions related to cardiac defects or disease, hearing or vision, developmental delays, sucking, feeding problems, cognitive ability, GI issues, thyroid issues, the atlantoaxial instability or that mobility of the spine, the hematologic problems, seizures, infections, growth and height and weight changes, the hypothyroidism, signs and symptoms of sleep apnea because of the obstructive sleep issues, and any other changes in the physical state or medical regimen. Look at the presenting illness or chief complaint. A physical exam may show certain physical features characteristic of Down syndrome. So look at the general appearance. Note the lack of muscle tone and the loose joints. This is more pronounced in infancy, and a baby with Down syndrome will have a floppy appearance. Plot the growth on the growth chart because the child with Down syndrome is going to grow at a slower rate. They have special growth charts for them. When assessing achievement of developmental milestones in the child with Down syndrome, it might be more useful to look at the sequence of milestones rather than the age at which they were achieved. Each milestone represents a skill needed for that stage of development. Perform a subjective assessment of the hearing and refer the child for further evaluation. Make sure you check the vision, especially for cataracts. Also monitor the respiratory and cardiac status. Listen for murmurs and changes in the lungs, which can indicate congenital heart disease. Look for chronic or recurrent respiratory infections such as pneumonia and ear infections. Some laboratory and diagnostic tests. Okay, it can be calculated incorporating the maternal age prenatally between 11 and 14 weeks using ultrasound and blood test, looking at that nuchal translucency. Remember, we're looking at that nuchal fold and the amount of fluid that's there. Also, pregnancy-associated plasma protein A and HCG around 16 and 18 weeks using that triple quadruple blood test. We're looking at, remember, the alpha fetoprotein, the human, the HCG, I can never say that right, and the estriol levels, okay, or the inhibin A levels. We're also using ultrasound, amniocentesis, and the chorionic villi sampling to detect any chromosome abnormality. Down syndrome can be confirmed after birth using chromosome analysis. So common lab and diagnostic tests to assess complications with Down syndrome would include the echocardiogram, looking at possible cardiac defects, vision and hearing screening, looking for those impairments, thyroid levels to detect thyroid disease. Remember, it's going to be most likely low. Cervical radiographies to look for the atlantoaxial instability, and ultrasound to assess for GI malformations. So these kids are going to grow slower. All right. Walk at and talk and reach developed milestones at a different rate. So you want to know the teaching guidelines. We want to know that we would give regular vision, hearing checkups. We'd be monitoring for signs and symptoms of respiratory infection because they're more likely to get them than other kids. We got to promote nutrition in early infancy. They may have difficulty with feeding and sucking because of that poor muscle tone. They may have a small mouth with a large protruding tongue, which may interfere with their ability to eat. They don't need a special diet unless they develop celiac disease or other GI complications, which they are prone to. Okay, and we would give them high fiber to help increase that gastric motility. We're going to provide support and education for the family. Developmental delays here could be mental mild to moderate. And how does the family define their experience? So that's what you want to ask about, see how it's going for them and what kind of things do they need. You're going to help the family connect, be able to get those available resources or find those available resources that can facilitate the child's growth and development. Teach them about early intervention programs that can help the child with things like speech, language, occupational, and physical therapy. This will help promote the child's growth and development. And then special education should fit the child's needs. The child should be integrated into mainstream education whenever possible. All right, so teach the family to have the child evaluated by cardiology, including echocardiograms, routine vision and hearing tests. Make sure the child gets regular medical care, immunizations, and a thyroid test at 6 and 12 months, and then yearly. Child should follow a regular diet and exercise regimen. Families should be instructed on how to do proper hand hygiene to prevent infections and how to monitor for signs and symptoms of respiratory infection like pneumonia and otitis media. Families should talk with the physician on the use of vaccines, especially pneumonia, RSV, and influenza. Early interventions are important with therapy education as well. Make sure the child brushes the teeth regularly and visits the dentist every 6 months, and the child should get the cervical radiography between 3 and 5 years of age to screen for that atlantoaxial instability. Any changes in the gait or use of arms, hands, legs, changes in bowel and bladder function, or complaints of neck pain, head tilting, torticollis, or generalized changes in function should be reported immediately. Ensure cervical spine positioning precautions to avoid overextending the neck are used during procedures. Build a trusting relationship with the parents. Try to stress the authenticity of their feelings. Reject your own personal biases. Recognize that clients cope in various ways and the family's behavior may not be what you would expect. So help the family identify what strengths, weaknesses, and supports they have available on their side and available to them, and know that the family's emotions may exhaust and disorganize them. Help the family members maintain open communication among themselves, provide referrals as needed, allow the family to verbalize their emotions and ask questions, and always ask the parents how they are doing. Trisomy 18, also known as Edwards syndrome, and trisomy 13, also known as Peteau syndrome, or other common trisomies. They're a lot more severe than the Down syndrome or the trisomy 21. The incidence of trisomy 18 and trisomy 13 are not as common. One happens, the trisomy 18 happens at about 1 in 6,000 births, and the trisomy 13 about 1 in 10,000 births. Okay, like Down syndrome, both of them are caused by non-disjunction during the cell division. The trisomy 18 and trisomy 13 can be present in all cells, or it can occur in the mosaic form, meaning what? Right, if you said it only happens in some of the cells, you're correct. Okay, both are associated with characteristic sets of anomalies and severe intellectual disabilities. The prognosis for trisomy 18 and 13 are usually very poor. These children don't usually survive beyond the first year of life. There's no cure for the trisomy 18 or 13, and therapeutic management is focused on managing the congenital anomalies and health issues associated with the disorders. So in trisomy 18, they will have the prominent occiput, the low set ears, the short eyelids, the severe intellectual disabilities, severe hypotonia, webbing, the clenched fist with the index finger overlapping the third digit and the fifth digit overlapping the fourth, hypoplasia of the fingernails, narrow hips, limited abduction, short sternum, and congenital cardiac defects. With the trisomy 13, we'll see a microcephalic head, wide sagittal sutures, fontanelles, malformed ears, small eyes, extra digits, severe hypotonia, severe intellectual disabilities, congenital heart defects, cleft lip, and cleft palate. Okay, this is Rick Santorum. He's a Republican presidential hopeful back in 2012, and he had a daughter. This is a picture of him with his daughter. And in the picture here, she's 3 years old. She suffers from the trisomy 18, and we already discussed that usually most kids die from this by the end of the first year, but this child has defied the odds. Okay, so in this question, in this picture here, she's 3 years old. All right, Bella is currently 13 years old, and the oldest person in the US that has this disorder that's still living is actually 40 years old. So we do have some people that survive it. All right, trisomy 13. In this disorder, the baby will have a microcephalic head, meaning small. They'll have that wide sagittal suture and fontanelles, the malformed ears, the small eyes, the extra digits, severe hypotonia, severe intellectual disabilities, congenital heart defects, cleft lip, and cleft palate. Usually nursing assessment includes general assessment for the characteristic anomalies, the pre-screening and the diagnostic tests. And if not diagnosed during the prenatal period, then most cases in the first few days of life based on the physical characteristics. So again, nursing management, mainly supportive. It's going to be a difficult time for the baby. So you're going to provide support and resources for the family, and an organization named SOFT, which helps families that have these chromosome abnormalities. So we talked earlier about chromosome structure abnormalities, and this is where the chromosomes break and they lose a portion of one or more of the chromosomes. And during the repair process, the broken ends are incorrectly rejoined together. This can involve the sex chromosomes. There are two types, Turner syndrome in females that we're going to talk about, and Klinefelter syndrome in males. So with Turner syndrome, this is an abnormality of the sex chromosome. The phenotype is the female, and it occurs in about 1 in 2,500. It's due to loss of all or part of one of those sex chromosomes. About half of the individuals affected have only one X chromosome, and the other half have a variety of abnormalities of their sex chromosomes and can present with the mosaic form, meaning less symptoms, right? It's not in all the cells. There's no cure for the Turner syndrome. So management focuses on health issues. These kids are more prone to cardiovascular problems, kidney, thyroid issues, skeletal disorders like scoliosis and osteoporosis, hearing and eye disturbances, learning disabilities, and obesity. Usually they'll be infertile. Okay, so they may have a spontaneous pregnancy, but very few have these spontaneous pregnancies. The growth hormone administration is a standard of care and usually starts when the child's height begins to fall below the 5th percentile for those healthy girls. Hormone replacement therapy may also be needed to start the puberty process and complete the growth process. So you're looking at the patterns of growth. With these girls, you're going to see short statute, slow growth. Some of them have that webbed neck, the low posterior hairline, wide space nipples, edema of the hands and feet, amenorrhea, and no development of the secondary sex characteristics. They can also become sterile and have a problem with their social skills. Okay, so you can see the webbing of the neck in this picture. The neck becomes like wide and spread out. This can be suspected prenatally through ultrasound findings with clinical manifestations like fetal edema or redundant nuchal skin. It also can be diagnosed through chromosome analysis prenatally or after birth. Some kids are diagnosed at birth in early childhood when their growth is slowed or when they fail to grow. And some don't get diagnosed until they reach puberty and that pubertal growth spurt doesn't occur. So management is going to be supportive here, education and support to the family, understanding that the short stature and the infertility are likely. Okay, hard for some parents to accept because their child's not going to be able to produce any grandchildren. And that could be a problem in some cultures. Okay, some cultures won't want their son to marry into a family where the girl's not going to be able to produce offspring. So resources and education, very important here. All right, Klinefelter syndrome. This is most common in men. Okay, or male. The karyotype and phenotype are male. So we have one extra chromosome present. The abnormality is usually caused by the non-disjunction during the meiosis, but they do have mosaic forms. The incidence of the Klinefelter syndrome is 1 in 500 to 1,000 males, and the male will present with some female-like features that are caused by the testosterone deficiency. So the recurrence of future pregnancies is not increased. The risk of recurrence in future pregnancies, is not increased. So it's not likely that mom will continue to have these types of babies. There's no cure for the Klinefelter syndrome. Therapeutically, we focus on interventions to enhance those masculine characteristics. So we might give testosterone placement. Early recognition is important. Cosmetic surgery maybe to minimize the female characteristics like the gynecomastia or the increase in that breast size. Due to nonspecific findings during childhood, diagnosis is not usually made until adolescence or adulthood. Prenatal diagnosis is rare unless the amniocentesis was performed for genetic testing. Many males with the Klinefelter reach adulthood without being diagnosed. Diagnosis is confirmed by the chromosome analysis. Lack of development of the secondary sex characteristics may be found. The individual may have a decrease in facial hair, the gynecomastia, the decreased pubic hair, and the hypogonadism or undeveloped testes, and this leads to infertility. Individual may be taller than average by 5 years with long legs and a short trunk or torso. Intellectual disabilities not usually present, but some cognitive impairments may occur, such as delay, speech, language difficulties, attention deficit, and learning disabilities. Management is supportive, providing education and support to the family, links to the American Association for Klinefelter Syndrome and the Association for XY chromosome variations provided. Counseling about infertility is important. Okay, so educate the children and the families that marriage and sexual relationships are possible. However, their son may not be able to reproduce. Fragile X syndrome. This is the most common inherited cause of intellectual disability. It's because of a mutation of a gene, the FMR1 Fragile X mental retardation on the X chromosome. The mutation essentially turns off the gene, triggering the Fragile X syndrome. The male and female are both affected, but it's most commonly seen in males, and affected females usually have milder symptoms. Inheritance is complex and less straightforward than the single gene or the Mendelian inheritance. Some carrier females are affected, and not all males with the gene show symptoms. Male and females are both fertile and can transmit the disorder to their offspring, so counseling is appropriate. Prognosis for individuals with Fragile X is good. They tend to live a normal life, and there is no cure for Fragile X syndrome. Therapeutic management focuses on multidisciplinary, aimed at interventions to improve the cognitive, emotional, and behavioral impairment. Clinical manifestations would be subtle with some minor dysmorphic features and developmental delay. Problems with sensation, emotion, behavior are usually the first signs. Delays in attaining developmental milestones will likely be the first clue found on assessment. Intellectual impairment can range from subtle learning disabilities to severe and autistic-like behaviors. Boys tend to present with characteristic features like the elongated face, the prominent jaw, the large protruding ears, the large testes, and a range of behavioral abnormalities and cognitive deficits. There's characteristic patterns to the cognitive deficits with problems in abstract thinking or reasoning, sequential processing, and mathematics. So behaviors include attention deficits, hand flapping, biting, hyperactivity, shyness, and social isolation. In females, clinical manifestations are similar, but more varied and present in a milder form. Diagnosis is confirmed with molecular genetic testing. Fragile X can be diagnosed prenatally if inheritance is suspected. Management is going to be supportive, early diagnosis and intervention, and an individualized education plan. Care of these children will require the same care as other children with intellectual disabilities, provide education to the family, and support through the National Fragile X Foundation. Okay, so just some of the signs and symptoms that you'll see there. Intellectual disabilities, hyperactivity, large head, long face, behavioral issues. All right, neurofibromatosis. This is also referred to as harmatosis. It's a group of disorders characterized by abnormalities of the skin and the central nervous system. Several neurological conditions are associated with cutaneous manifestations because the skin and the nervous system share a common embryologic origin. There are complex conditions and most affect other organs such as the eyes, the bones, the heart, and the kidneys. Most are hereditary and follow an autosomal dominance inheritance pattern or a sporadic occurrence. Neurofibromatosis is a common neurocutaneous syndrome and genetic disorder of the nervous system that affects the development and growth of the neurocell tissues. There's different types: neurofibromatosis 1, neurofibromatosis 2, and schwannomatosis. Neurofibromatosis 1 is the most common type. This disorder causes tumors to grow on the nerves and produce other abnormalities such as skin changes and bone deformities. The affected person will inherit the disorder in most cases. However, about half of the cases, many people inherit the disorder. However, in about half of the cases, we see a new mutation. The inheritance pattern is autosomal dominant. So offspring of affected individuals have a 50% chance of inheriting the altered gene and presenting with symptoms. Neurofibromatosis is due to a mutation of the neurofibromin gene on chromosome 17. So it's autosomal dominant. It also referred to as elephant man disease, can be seen on the skin and uterus, and tumors grow on the nerves and the tissues. Complications associated include headaches, hydrocephalus, scoliosis, cardiac problems, hypertension, seizures, vision and hearing loss, neurocognitive defects, learning disabilities, attention deficit disorder, fine and gross motor delays, autism, behavior and psychosocial issues, and abnormalities of speech. Also, a higher risk for development of these neoplasms. There's no cure for it. Therapeutic management is aimed at controlling and managing the complications. Surgical intervention can help reduce some of the bone malformations and remove some of the painful or disfiguring tumors. These children should have a yearly physical, assessing blood pressure, cardiac function, scoliosis screening, ophthalmology, and developmental screening, as well as a neuro exam. Okay, on assessment, you may find something called cafe au lait spots. These are light brown macules, and they're the hallmark of the neurofibromatosis. They're usually present at birth, but can appear during the first year and start to increase in size and pigmentation. They present all over the body, especially the trunk and extremities, sparing the face usually. The pigmented nevi, axillary freckling, and slow growing cutaneous and subcutaneous or dermal neurofibromas, which are benign tumors and other signs of neurofibromatosis. Many children with the neurofibromatosis have larger than normal head circumference and are shorter than average. Diagnosis is made if the following are present: 6 or more cafe au lait macules, greater than 5 mm in size, in diameter in children, and greater than 15 diameter in adults and adolescents, 2 or more neurofibers, or 1 plexiform neurofiber, freckling in the armpit or the groin, presence of an optic glioma, 2 or more growths on the iris of the eye, abnormal development of the spine, the scoliosis, the temple bone of the skull, or the tibia, and a first-degree relative with the neurofibromatosis. So here you see a neurocutaneous disorder called tubular sclerosis. Okay, and these benign tumors are present in the brain and on the skin. They often are involving the heart, the lung, the kidneys, the bones, the eyes. These patients can have generalized seizure disorders, developmental delay problems, and it's usually evident in childhood. Also, they can have severe intellectual disabilities. So treatment is mainly symptomatic with the goal to prevent the treatment-associated complications, with the goal to prevent and treat associated complications. Seizure control will be a primary concern, provide support and education to the family, and then refer for genetic counseling. Also, they have the Tuberous Sclerosis Alliance that you can refer the family to. Sturge-Weber syndrome. In this, you'll see the facial nevus or the port wine stain, usually on the forehead or one side of the face. These clients are subject to seizures, hemiparesis, intracranial calcifications, intellectual disabilities, behavior, emotional problems. And seizures can start in infancy and get worse with age. And a lot of times they're noted on the side of the body with the actual nevus. Muscle weakness can also be present on that side. And most individuals have glaucoma at birth or it develops later. Treatment is mainly symptomatic. Seizure control is a main issue. Laser treatment to remove or lighten the facial nevus, surgery for the glaucoma, and then PT for the muscle weakness. Educational therapy on the intellectual disabilities and developmental delays, then support and education to the family, as well as genetic counseling. Apert syndrome, this is the recognizable pattern of congenital anomalies where we see coloboma, heart disease, atresia, which we talked about the other night, retarded growth and development or central nervous system anomalies, genital anomalies, hypogonadism, ear anomalies, and deafness. It's an autosomal dominant inheritance. Most cases are due to new mutations on the gene CD87, and it typically occurs during fetal development, affecting multiple organ systems. So the coloboma is a lesion or a defect of the eye. Heart disease can be any type. The atresia is usually choanal, retarded growth, the genital anomalies, and the ear anomalies and deafness. Focus is on identifying and treating all the defects, and early diagnosis is important. So this atresia choanal is a blocked or narrowed passageway from the nose to the throat, leading to aspiration. And then Marfan Syndrome. Okay, Abe Lincoln had this. You can tell by looking at him. This is a disorder of connective tissue. It's an autosomal dominant inheritance caused by a mutation in the gene fibrillin-1, which results in changes in the connective tissue itself. The primary involvement includes definitely the heart, skeletal muscle tissue. Okay, these patients are going to be tall, statue with long, slim arms, that long face, a small amount of subcutaneous fat, muscle hypotonia, loose joints, a long and narrow face again. And so some other things that you'll see, a lot of issues with the heart, especially with the mitral valve and the aorta. Delayed achievement of gross and fine motor milestones can occur with this. No contact sports, and we want to prevent any complications. And then they do have a Marfan syndrome that you can also refer the patient to. There you go, Abe Lincoln. Vater association is not a diagnosis. It talks about a random association of defects that occur together. So V equals vertebral defects. A is anal atresia. TE is tracheoesophageal fistula with esophageal atresia, which we talked about the other day. Radial and renal dysplasia may also occur as bacterial associated with cardiac anomalies and limb abnormalities. It's of sporadic inheritance. Cause is unknown. Can occur with other chromosome abnormalities like trisomy 8, and it's often seen in offspring of diabetic mothers. One anomaly is present in 3 body parts: the limb, thorax, lower abdominal pelvis. Anomalies seen in hypoplastic small vertebrae or hemivertebrae, only half of the bones are formed, and these anomalies lead to the increased risk for the scoliosis. They have an imperforate anus or anal atresia. So the anus doesn't open to the outside of the body. And then the tracheoesophageal fistula or esophageal atresia, which leads to increased risk for aspiration, feeding, and swallowing problems, because the stomach's not connected to the esophagus is not connected to the so in the esophageal atresia, the esophagus is missing that connects the or that tube is missing that connects the esophagus to the stomach. Okay, other things, cardiac anomalies, absent or displaced thumb, polydactyl extra digits, syndactyl fusion of digits, single umbilical artery at birth, failure to thrive, and focuses on identifying and treating all the different defects. The Apert Syndrome. This is named for a French doctor who described it. It's an autosomal inheritance, autosomal dominant inheritance. Cases are sporadic. It involves craniosynostosis and maxillary hypoplasia with a flat recessed forehead, a flat midface, bilateral symmetric syndactycal and craniofacial anomalies like a high arched palate and associated clefting, short anterior posterior diameter, protruding eyes, down slanting eyelids, low set ears, small nasopharynx, leading to upper airway obstruction and sleep apnea, and then acne vulgaris, strabismus, hearing loss, learning disabilities, and mental deficiencies. So remember the syndacty, that's the fusion of the fingers. The polydactyl is when you have extra digits. Earlier in this video, I said syndactyl was the extra digits. It's actually polydactyl that are the extra digits, and the syndactyl is the fusing of those digits. So early surgery for the craniostenosis, if the baby presents with increased intracranial pressure, all right, and then management with the multidisciplinary approach team to address the multiple anomalies. Achondroplasia, this is the most common chondrodysplasia. Okay, and it's an autosomal dominant inheritance pattern caused by different mutations in the fibroblast growth factor receptor 3. It's characterized by abnormal body shape, small stature, a height of 4 feet or less for men, and short limbs with normal torso size. Also, low nasal bridge with prominent forehead, mid-face hypoplasia, caudal narrowing of the spine canal, megalocephaly, small foramen magnum. The hands are short and stubby with the separation between the middle and ring fingers, called a trident hand, delayed motor skills. Medical management of the symptoms, we're monitoring for the height and the weight, the head circumference, and we need to prevent complications through neurological exams, assess for sleep apnea. We'll possibly give the growth hormone therapy, but right now it's still controversial and in the experimental stages, and then limb lengthening surgeries. Some of you were asking about this limb lengthening surgery, and I'm just going to tell you a little bit about it. They do it using the body's own ability to regenerate new bones, soft tissues, ligaments, blood vessels, and other nerves that surround and support it. So they started with an osteotomy where the orthopedic surgeon cuts the bone to be lengthened, the limb, usually the upper or lower leg, and then it's stabilized using different methods or external or internal devices or frames. 2 phases of the recovery follow. In the first, the distraction phase, the bone that is cut is very gradually pulled apart in a process that promotes distraction osteogenesis, or new bone growth at the site of the ostomy. And then continued growth of the new bone tissue is accomplished by distracting or spreading that gap 4 times a day 1/4 of a millimeter with each adjustment. As the space between the ends of the bone opens up, the body continues to produce new tissue in the gap until the desired length of the bone has been generated. Additional strategies are available to correct any deformity that may be present, such as misalignment of the bone from trauma or birth. Early in this phase, patients walk with the aid of crutches in order to regain mobility. So it's a gradual process of lengthening, and it happens over time by regenerating new bone through natural processes or stimulation processes. Okay, now we're to the inborn errors of metabolism. This is a group of hereditary disorders that are usually rare, but they follow an autosomal recessive inheritance pattern, most of them. They're caused by gene mutations that result in abnormalities in the synthesis or the catabolism of proteins, carbohydrates, or fat. So the body can't convert the food into the energy as it normally would. So there's either a defect in the enzyme or in the transport protein that blocks the metabolic pathway. The blocked metabolic pathway then allows for the accumulating damaging byproduct, okay, of the impaired metabolic process to build up, and that can cause problems. So presentation can occur at any time, but most likely in adulthood. Many affected individuals may exhibit signs in the newborn period or shortly after. Inborn errors of metabolism present in the neonatal period are lethal if specific treatment is not immediately issued. So we do this newborn screening to detect the disorder before the symptoms develop. So one of those is the phenylketonuria or the PKU. So we get this single drop of blood, okay? And we can test for multiple different things in the child. Therapeutic management involves depending on the cause of the error of the metabolism, but dietary management is often a key component. So because the newborn screening and early identification and management, it is rare to see an untreated newborn with clinical signs and symptoms of the disease caused by one of the inborn errors of metabolism disorder. If seen, a newborn who was healthy at birth will often present with lethargy, poor feeding, apnea, tachypnea, recurrent vomiting, altered consciousness, failure to thrive, seizures, septic appearance, or developmental delay. Physical changes that may be seen include dysmorphology, cardiomegaly, rashes, cataracts, retinitis, optic atrophy, corneal opacity, deafness, so on and so forth, jaundice, cirrhosis. When a previous healthy newborn presents with a history of deterioration, suspect an inborn error of metabolism. So diagnostically, specific lab studies. Glucose may be elevated, ammonia may be elevated, blood gases may have low bicarb and low pH, metabolic acidosis, respiratory alkalosis may also be seen, especially if high ammonia levels are present. Early diagnosis is the key. In the inborn error of metabolism, if an inborn error of metabolism is suspected, feedings are usually stopped until test results are received. Ensure the diet prescribed for the infant is followed. For amino acid disorders like PKU, okay, we want to make sure that we test for this in the first few hours after the baby's born. So we're going to wait until the baby takes in some milk, and then we're going to test for this because we have to see how the baby responds to the protein once it's taken in. All right, so for PKU, this is a deficiency in the liver enzyme, and it impairs the ability to process the essential amino acid phenylalanine. The phenylalanine accumulation causes brain damage. So unless the PKU is detected soon after birth and treated, it'll lead to permanent irreversible brain damage. The baby's not going to have any signs at birth. Most cases are identified before symptoms are present due to newborn screening. If undiagnosed, the most common is developmental delay, vomiting, irritability, eczema-like rash, mousy odor to the urine, microcephaly, seizures, and behavioral abnormalities. So they'll be on a low phenylalanine diet. It's found mostly in protein-containing foods such as meat and milk, including breast milk and formula. So this child will have to have a special formula for PKU baby. So low phenylalanine diet, cannot use breastfeed or regular formula, lifelong protein. Must have breast milk or formula for the first 24 hours prior to the test. Okay, and then we'll complete the test prior to discharge. If you can't complete it prior to discharge, then we'll have to do it in the home setting. And a repeat test at 2 weeks is also recommended. So you can watch this YouTube video on metabolic screening. Other inborn errors of metabolism are galactosemia, and this is the inability to convert galactose from lactose, the inability to convert galactose from lactose. I'm almost done. They have a deficiency in the liver enzyme needed to convert galactose, the breakdown product of lactose, which is commonly found in those dairy products. Okay, so no symptoms at birth, and if undiagnosed, the newborn will have jaundice, feeding intolerance, diarrhea, vomiting, and no weight gain. And then they'll start to develop symptoms of sepsis, and cataracts are also often seen. If left untreated, it can lead to liver disease, blindness, and severe intellectual disabilities and death. Ingestion of galactose can produce sepsis in an affected child. So septic workup and antibiotics may be necessary if the child has galactose ingestion. Elimination of galactose and lactose from the diet is the only treatment. So milk and dairy products will be eliminated for life. Maple sugar urine disease affects the metabolism of amino acids. It's a deficiency in the enzyme that metabolizes leucine, isoleucine, valine, which are components of protein, often referred to as the branch chain amino acids. These amino acids accumulate in the blood and cause damage to the brain. No symptoms at birth, but if untreated, baby shows neurological signs, vomiting, poor feeding, increased reflex, and seizures. Lower the intake of protein. Lowering the intake of protein, as what occurs with breastfeeding, may delay the presentation of symptoms if untreated and can lead to life-threatening neurological damage. These babies will need a special low-protein diet based on the severity of the symptoms, limited natural protein, supplements such as BCAA-free, thiamine supplements. Diet must be continued throughout life, and then a liver transplant could possibly occur with good results. Biotinidase deficiency. This is lack of the enzyme biotinidase. There's usually no symptoms at birth, okay, in the first few weeks or months of life. Then they'll start to develop hypotonia, uncoordinated movement, seizures, developmental delay, alopecia, seborrheic dermatitis, hearing loss, optic nerve atrophy, and intellectual disabilities. Also metabolic acidosis, which can cause death. So they'll be given daily oral free biotin. And then medium chain acylo-CoA enzyme dehydrogenase deficiency. Okay, so this is due to the lack of the enzyme MCAD, which is required to metabolize those fatty acids. And classic presentation is a child 3 months to 5 years old with vomiting and lethargy after a period of not eating or fasting, like when they've been ill from a viral illness or something like that. Recurrent episodes of metabolic acidosis, hypoglycemia, lethargy, seizures, liver failure, brain damage, coma, and this can lead to serious fatal illness if the child is not eating well. So these children, we won't want them to fast. They have to have frequent meals, L-carnitine supplementation, particularly if they're ill, special considerations during illness. If unable to tolerate food, then they may need IV dextrose for energy. And that's so they're not trying, their body's not trying to break down the fat for energy. Homocystinuria, this is unable to digest methionine, the deficiency in the enzyme needed to digest a component of a food called methionine, which is an amino acid. So no symptoms at birth. In the first few months of life, symptoms will include vomiting, poor feeding, failure to thrive, hypotonia. If undetected and untreated, it can lead to intellectual disability and psychiatric disturbances, developmental delay, displacement of the lens of the eye, abnormal thinning and weakness of the bones, formation of thrombus in the veins and arteries, leading to life-threatening complications and stroke. These patients are given vitamin B6 and B12 supplements, possibly other supplements like betaine and folic acid, methionine restricted diet, and cysteine supplements, aspirin and dipyridamole to decrease the thromboembolic events. The tyrosinemia deficiency, this is an enzyme in the essential in the metabolism of tyrosine. So we get the accumulation of the byproducts, and that results in liver or kidney damage. Symptoms will usually appear in the first months of life, leading to fever, failure to thrive, poor weight gain, vomiting. They'll have that cabbage-like odor. This is the one where they get that odor in the secretions of that cabbage or that rancid butter smell. Enlarged liver and spleen, increased bleeding tendency, distended abdomen, jaundice, cirrhosis, and liver failure. So they'll need a diet low in both phenylalanine and tyrosine. Tay-Sachs, this is mostly seen in the Jewish population. It's caused by an insufficient activity of an enzyme called hexosaminidase and that's necessary to break down certain fatty substances in the brain and the nerve cells. It occurs more frequently among persons of the Ashkenazi Jewish descent, with 1 in every 25 being a carrier. Infants appear normal and healthy in the first few months of life. Then as harmful quantities of the fatty substances build up in the tissue and the nerve cells, it begins to cause damage. Mental and physical deterioration occur. The child will become blind, deaf, and unable to swallow. The muscles begin to atrophy and paralysis sets in, leading to dementia, seizures, and an increased startle reflex may also be seen. There is a late onset type of Tay-Sachs seen in people in their 20s and 30s, but it's much rarer. There is no treatment or cure for Tay-Sachs. Medical management focuses on managing symptoms and maintaining comfort. Anti-seizure medications may be given. Death usually occurs in the child by age 4 or 5. The carrier can be identified through a blood test and prenatal testing. And then they have the National Tay-Sachs Ally for support. The nurse is assessing a child for a genetic disorder that a musty odor emanates from the child. What disorder would the nurse expect? Hopefully you said PKU. Remember maple syrup? They'll have that burnt sugar or maple smell. The tyrosinemia, they'll have that cabbage-like smell. Okay, and then the trimethylaminuria, they should have that rotten fish-like smell. Okay, that concludes this lecture.